All right, welcome everybody. I have the honor and privilege of kicking off the 2024 Grand Round season by introducing Ryan Tedford. Dr. Tedford is a professor of medicine and holds the Dr. Peter C. Gazy's Endowed Chair in Heart Failure at the Medical University of South Carolina, or MUSC. He is the section head of heart failure and the head of their cardiac transplantation as well. He also leads their fellowship program. He is an internationally recognized clinician researcher and has published over 200 manuscripts. His research is focused on the hemodynamic assessment of the RV and its interaction with the pulmonary circulation in the heart. As such, he is a world expert in the fields of pulmonary hypertension, left heart disease, exercise physiology, hemodynamics, and mechanical circulatory support. He was the co-chair of the PH associated with left heart disease task force for the recent World Symposium in Pulmonary Hypertension that wrapped up in June this year in Barcelona. He's the deputy editor of the Journal of Heart and Lung Transplantation and serves on the editorial board for many other journals. He is also our inaugural CAFE Scholar. The CAFE Scholar program is, of course, the Cardiovascular Academia and Football Exchange program. As part of the program, Dr. Tedford will teach us about the people's ventricle, a topic his name is synonymous with. And we will teach Dr. Tedford about football, specifically championship football. Texas has a long history of losing many more games than the University of Michigan. As everyone knows, the University of Michigan is the winningest program in the history of college football. And we are, of course, the reigning national champions. And so we look forward to welcoming Dr. Tedford and his Longhorns to the Big House on Saturday, but there's work to be done before then. And so without further ado, Dr. Tedford will talk to us about the people's ventricle.
Thanks very much, Tom. I hope somebody got a picture of the inaugural CAFE professor. I'm very, very honored to be here and happy to talk about the right ventricle with you all. These are my disclosures, none of which should be particularly relevant for this afternoon, but Tom alluded to a few others that I have. One is that I believe the RV is the most important ventricle, and I love talking about it. And secondly, as Tom alluded to, I love college football, and I bleed orange, more specifically burnt orange, as I went to the University of Texas. And I'm a bit of a college football historian, and so Tom pointed out the wins for Michigan, but what you may not know, these two historic programs, Michigan and Texas, have only played one time before, which is pretty remarkable. And if you missed that, I have a little video here to show you the end of that game, just in case you might have missed it here. Wait for it. And there it is. I actually injured my ankle jumping up and down after that kick. Now, whenever I point this out to Dr. Casino, he reminds me the last time Texas won the national championship, I still had hair. So congratulations on your national championship, and I really do look forward to the game on Saturday. So these are the objectives I'd like to meet with you over the next 45 minutes. We're going to describe the major determinants of right ventricular function and its importance in various disease states. We're going to spend a lot of time appraising both traditional and emerging tools to assess right ventricular function, including the role of right ventricular reserve. And we're going to talk about that in the context of left ventricular assist devices, where right heart failure is a major problem. And then at the end, we're going to construct a framework to predict, mitigate the risk of, and manage right heart failure. So back in 1943, Sir Isaac Starr published this paper in the American Heart Journal with his colleagues. And figure one here shows the heart of a dog. And the right ventricular wall has been completely cauterized, so it completely lacked function. And when Dr. Starr and his colleagues observed only a minimal increase in peripheral venous congestion, they concluded that weakness of the right side of the heart seems less important. So it turns out, even back in 1943, there was such a thing as fake news. Of course, we now know that right ventricular failure is a significant contributor to morbidity and mortality in many of the conditions you and I treat every day. So how do we best assess the right heart? This is a review that we wrote in the New England Journal last year, where we talk about the determinants of right ventricular function, the same ones that determine left ventricular function, And those are preload, afterload contractility, and lusitropy. And it turns out, particularly in the right heart, they're all interconnected, so that perturbations in one will impact the other. And very quickly, you create this vicious spiral, or the spiral of right heart failure and death, as we like to say. And so how do we use this construct as we think about how we should assess the right ventricle? It's particularly important in the RV because of the afterload sensitivity of the RV. Now, any RV talk you've ever been to has probably shown this figure. I can see Dr. Pagani out in the audience. I know he's seen this probably 1,000 times, but it simply shows us in the acute setting that the right ventricle is more afterload sensitive than the left ventricle. An increase in mean pulmonary pressure of just 15 millimeters of mercury resulted in a decline in stroke volume by about 30%, where the LV, an increase in 40 millimeters of mercury in mean arterial pressure, only reduced stroke volume by about 10%. But I think what is less appreciated is that the RV remains afterload sensitive even in a chronic setting. So very elegant work done by the late John Newman at Vanderbilt took patients who had vasoreactive pulmonary hypertension and measured hemodynamics before and after administration of nitric oxide. Now, by definition, and as you would expect, those individuals had significant decreases in afterload as assessed here by pulmonary vascular resistance, and this was met by an increase in stroke volume. So what this tells us, if we just consider the right ventricle's state independent of afterload, we may not really get a good sense, or in the context of afterload, we may not get a good sense of the intrinsic ability of the right heart to stiffen and contract. So what is the gold standard? If you've ever heard me talk about the right ventricle before, you know I have to show pressure volume loops, and today is no different. So we're going to start out with a cartoon of an RV pressure volume loop. This represents a single cardiac cycle. We're going to begin here at the end of diastole. This is our preload, or our RV end diastolic volume. The tricuspid valve is just closed, initiating the onset of systole. We first have isovolumic contraction. We have a rise in RV pressure without any change in volume, at which point the pulmonic valve opens. We begin ejecting blood into the pulmonary circulation, the fall in volume without much change in pressure. The pulmonic valve closes then, initiating the onset of diastole. We have our isovolumic relaxation, a fall in pressure without any change in volume, at which point the tricuspid valve opens and we fill the right ventricle again. And the width of that pressure volume loop is, of course, our stroke volume. Now, how do we construct these pressure volume loops? Well, traditionally, this is done with a conductance catheter. This is a catheter that allows for both simultaneous measures of pressure and volume. There's a pressure transducer on the pigtail tip here, but you also note there's these electrodes spaced about 1 centimeter apart. And when this catheter is placed in the RV apex here, we apply electrical current to those electrodes, and then we measure the voltage differences between those electrodes, and those are inversely proportional to the segmental volume between those electrodes. We can then add up those segmental volumes to get a relative volume of the RV, which we can calibrate with either same-day MRI or 3D echo, or another methodology called the Bond method using hypertonic saline. Now, pressure volume analysis also allows for measures of RV contractility independent of afterload. And this is based on the principle that the RV is an elastic structure that will stiffen and relax along a predictable time course in the cardiac cycle. So if we create a family of pressure volume loops, commonly through preload reduction, we find the end systolic pressure for each one of those loops. This is the maximal ratio of pressure and volume. And the slope of those dots is the end systolic elastance. This is a relatively load-independent measure of contractility. So how do we achieve preload reduction? Well, my mentor, David Cass, would do that with IVC balloon occlusion back in the 70s and 80s. But there's also less invasive ways to do that. We can leverage the Valsalva maneuver, for example. During phase 2 of the Valsalva maneuver, we can see significant reductions in RV volumes when that occurs. And we showed a good correlation between traditional IVC balloon occlusion and Valsalva preload reduction methodologies when determining measures of contractility. Afterload on the pressure volume loop can also be assessed, and it turns out that if we could sum up pressures throughout ejection, this would be a good estimate of afterload. And so therefore, if we take our end systolic pressure and divide it by the stroke volume, this gives us the effective arterial elastance. This is a lumped parameter of afterload that accounts for not just resistive load, our traditional PVR that we measure in the cath lab, but also the impact of pulsatile flow and wave reflections that can return during ventricular systole to further elevate afterward. We then look at the ratio of those two elastances, which is a unitless measurement of RV-PA coupling, the so-called gold standard of ventricular function, how the RV and the pulmonary circulation are actually interacting. So the first RV pressure volume loop, to my knowledge, was done by Lowell Mon and Mike Weisfeld in the basement of Johns Hopkins back in 1979. You'll notice that pressure volume loop is a little bit different than what I showed you earlier. It's much more triangular in shape, and that's because these were normotensive dogs. And the reason for this fall in pressure throughout ejection is because the RV is ejecting into a very low impedance circuit. There's not much afterload there. But they were able to show that that end-systolic pressure volume relationship was sensitive to inotropic stimulation with epinephrine and dobutamine, as well as negative inotropes like Esmol. This is actually a pressure volume loop in a patient with pulmonary hypertension. You'll notice the shape actually changes again. Now it's much more trapezoidal in nature. We see a rise in pressure throughout ejection. And in fact, pressure peaks at the end of ejection, and that's a result of those reflective waves that were returning during ventricular systole, a result of a non-compliant pulmonary vasculature. So we've used this methodology in a number of different scenarios. One was to try to understand the disparate outcomes we've seen in patients with systemic sclerosis-related pulmonary hypertension compared to idiopathic pulmonary hypertension, just as a figure of just two examples here. But you can see the slope of that end-systolic pressure volume relationship is much shallower in patients with scleroderma compared to idiopathic pulmonary hypertension, indicating reduced contractility. Importantly, in the larger cohort, no differences in conventional imaging or hemodynamics between these groups. We've also shown that these methodology can predict time to clinical worsening in patients with pulmonary arterial hypertension, despite having overall preserved ejection fraction via MRI. And then most recently, in collaboration with Coder Tello and Tim Lamb, have shown that women tend to have better contractility and RV-PA coupling than men, perhaps accounting for the disparate outcomes between those two genders in pulmonary hypertension. So this is one of my favorite quotes from Stephen Hawking. It says, "Time travel may be possible, but it's not practical." What he's also said after a couple of gin and tonics is PV loops may be possible, but not practical. And so if they're not practical, what are our next best methodologies? One of the methodologies that is gaining a lot of notoriety, especially in the research field, is the so-called single beat approaches to RV-PA coupling, or single beat estimates of RV elastance. This does not require preload reduction. And so the basic way that this works is that we have our RV pressure tracing, and we fit a sine wave to the isovolumic portions of the RV pressure tracing. So here during contractility and here during relaxation. And the peak of that sine wave is our P max, or a theoretical pressure that the RV could generate if it were to eject into infinite afterload. You can then pair P max with our end diastolic volume. We know our end systolic pressure and our end systolic volume. We connect these two dots, and now we have our slope, our load independent measure of contractility. In this animal study of normotensive dogs, it was a very good correlation between that predicted Pmax from this methodology and the observed Pmax when they actually tied off the pulmonary artery of these dogs. How do they compare with our multi-beat approaches? I would say that the literature is somewhat disparate, but in general, there's been a good correlation between the multi-beat approach and the single beat approach, but it is highly dependent on those points you select in the isovolumic portions of the RV pressure tracing. And so what I think this really means is if we're going to use this for research purposes and ultimately clinical purposes, it has to be an automated system, right? So we don't rely on manual point selection. And so with that in mind, we've partnered with Rebecca Vanderpool. She's at a little community college called Ohio State. And we've used that to actually try to understand differences with implant approaches for LVAD. So a sternotomy versus thoracotomy. Here you can see the patients who underwent a sternotomy approach had a significant decline in load-independent contractility after implantation, where the thoracotomy patients with a less invasive approach actually preserved their contractility better than those with sternotomy. Well, can we make it more simple? What about just the right heart cath lab? I was happy to hear you guys have a dedicated lab just to right heart cath and biopsies. That's wonderful. What of those measures that we do in the right heart cath right heart cath lab actually correlate best with RV contractility. So a really nice study done by Stephen Sue at Johns Hopkins, where he took myocytes from patients with failing RVs, skinned those myocytes, and connected them to a force apparatus, exposed them to different calcium concentrations to develop these force tension curves. You can see here the open dots represent the RV failure patients, and you can see their maximal force generation is less than non-failing controls. He then looked at the correlation between that and our hemodynamic measurements, and what he found was it was the PAPI, the pulmonary artery pulsatility index, the pulmonary pulse pressure divided by the right atrial pressure, was the hemodynamic measure that correlated best with that individual RV myocyte function. So I think PAPI can be very helpful. I want to give you a word of caution with PAPI. Right atrial pressure, of course, is in the denominator of that equation. I think if our right atrial pressure is normal to low, it becomes much less robust, right? So if you have an RA pressure of 2 versus 4, probably not a lot of clinical difference in that patient, yet it will double or half your PAPI depending on which way you do it. And so I think PAPI is actually only useful if the right atrial pressure is in fact elevated. What about in the echo lab? And I am not an RV expert, but there have been a couple of different measures that have been suggested as a surrogate for RV-PA coupling. One is the so-called TAPSI to PAPSI ratio, right? So how much that tricuspid annulus moves towards the apex divided by the estimated pulmonary artery pressure. In this study from the folks from Gießen, we found at least a modest correlation between the ratio of TAPSI, PAPSI, and the single beat estimates of RV-PA coupling. What about strain? I think strain is a really great methodology, but I want to make sure that folks understand that it is not a measure of contractility. In fact, in this study, also from the Tello group, there was no correlation between any type of the strain measures and load-independent contractility. But what is it a surrogate of? It's really a surrogate of coupling. So here, a long axis RV global longitudinal strain was inversely proportional to the single beat measures of RV-PA coupling. So probably a pretty good surrogate for RV-PA coupling, which is really what we want to know. There's, of course, more to RV function than systolic function. We also have to consider diastolic function. And if we create that same family of pressure volume loops, we define the end-diastolic pressure volume relationship. It's a little bit more complicated because it's curvilinear, so a little bit harder to report and a little bit harder to construct. But nonetheless, you get the sense here, if the RV becomes stiffer and that end-diastolic pressure volume relationship is shifted upward and to the left, you can have a decline in stroke volume without any change in contractility, right? So similar to the patients with HFpEF, why they can have a reduced stroke volume in the LV. So there's been work with this multi-beat approach in patients with HFpEF. This is early and mild HFpEF. I want to be very clear with that. But in this work, again, from Rommel and colleagues, what they actually found is no differences in RV contractility. In fact, contractility was a little bit higher in the patients with HFpEF, but they had a sense here that the RV was more stiff in the HFpEF patients compared to controls. There were also single beat estimates of that end diastolic pressure volume relationship, taking the beginning diastolic pressure from the RV pressure tracing, the end diastolic pressure and the 0 point. You can then fit a nonlinear curve through those 3 points, couple that with your end systolic and end diastolic volumes to create a single beat estimate. And finally, published last year, perhaps a less invasive surrogate, the ratio of S prime to right atrial area index may be a surrogate for RV stiffness and perhaps actually perform better than many of those suggested in the guidelines of measures of diastolic function. But I think the other kind of take-home point is that all of these in isolation are going to have limitations, right? So this is just a table from the ESC ERS PH guidelines. When it talks about risk prognosis in patients with pulmonary hypertension, you'll notice a lot of it has to do with how the RV is doing. And what they're really pointing out here is that having multiple measures of right ventricular function is probably going to give you the best assessment of what the RV is actually doing. So I want to shift gears a little bit now and talk about RV reserve and how it may be a surrogate for what we really want to know. So what is reserve? Contractile reserve is the capacity of the ventricle to increase contractility at a given level of loading. That's commonly done with exercise or pharmacologic stressors like infusions of dobutamine. We've done this for years, right, in the left ventricle in patients with kind of low flow, low gradient aortic stenosis to determine if that valve is really narrow. We might do this to risk stratify patients with peripartum cardiomyopathy to see if they can tolerate another pregnancy, but it really, up until recently, hasn't been used to assess right ventricular function. So I first want to share with you that we can correlate RVPA coupling with evidence with amount of the reserve capacity of the right ventricle. This is an animal study of piglets with pulmonary hypertension, where the investigators performed pressure volume analysis and then gave those piglets dobutamine and looked at changes in stroke volume index. You can see here the pigs that had the most severe uncoupling had the least increase in stroke volume index, as opposed to pigs that had preserved coupling with the most significant increase. And there was a relatively linear relationship between relative stroke volume index reserve and RVPA coupling. So how does this translate into our patients with heart failure? This is a study from Marco Guazzi in Milan, where he took almost 100 patients with HFrEF who had undergone two tests. One, a cardiopulmonary exercise test to assess functional capacity, and the other was an exercise echo. Now, he first grouped these patients into, or subdivided based on their resting function. So group A had preserved RV function defined by TAPSE greater than 16. The red group here had abnormal function, but then he further subdivided this group based on the presence or absence of reserve. So during exercise, could they maintain or increase their TAPSE, which is group B, or group C actually had a decrement in TAPSE during exercise. He then looked at the differences in functional capacity between the groups. So group A, again, normal resting function. Group B, abnormal but had reserve capacity, were clinically indistinguishable, right? They had similar VO2, similar peak O2 pulse and estimate of stroke volume, similar degrees of exercise oscillatory ventilation, and similar VE/VSO2 slope. But it was group C, the ones that were lacking reserve capacity, that were markedly different. Lower peak VO2, lower peak O2 pulse, higher VE/VSO2 slope, and more exercise oscillatory ventilation. Barry Borlaug has also shown us in HFpEF that there's evidence of reserve impairments. In this study with 50 patients with HFpEF and 24 controls, no difference in resting cardiac output or stroke volume, no differences in resting function, but during exercise, you can see marked differences in RV contractility defined as changes in RVS prime in the HFpEF versus controls. So RV reserve may diagnostically be useful, but does it have prognostic value? This is a study out of Japan of 100 patients with dilated cardiomyopathy who underwent dobutamine stress echo and then were following for subsequent heart failure events. 3 different ways they assessed RV reserve here: fractional area change, TAPSE, and RV free wall longitudinal strain. I'll just have you focus down at the bottom panel here, but you can see the patients that had RV reserve, that is their global longitudinal strain improved with dobutamine infusion, were less likely to have a heart failure event, whereas those individuals who had a heart failure event really lacked any reserve capacity. These are all patients who have left heart failure. And then the last study I'll show you comes from Greg Lewis at MGH, where he looked at a large cohort of patients with congenital heart disease, developed an RV score, in fact, based on the peak exercise RV ejection fraction, as well as how much the RV actually augmented. And you can see those with the most severe impairment, with the highest score, had the least event-free survival at 2 years of follow-up. So it does appear that RV reserve can offer both diagnostic and prognostic information in our patients. Now, we wanted to look at RV reserve capacity in our patients with scleroderma pulmonary hypertension and idiopathic pulmonary hypertension, and we made some interesting observations when we did that. So here, the idiopathics are the open circles, the scleroderma are the black squares. And you can see during exercise, stage 1 is 15 watts, stage 2 is 25 watts, that the scleroderma patients actually began to dilate. That is, they had increases in their end-systolic and end-diastolic volume. And that's really shown here in this patient with scleroderma, that you can see with each stage of exercise, there's a shift of that pressure volume loop to the right, indicating higher volumes. And so although stroke volume was no different between the two groups, ejection fraction actually fell because the RV was dilating more. So we thought this was a fairly interesting observation and went on to show that we could correlate exercise RV ejection fraction to resting RV PA coupling during submaximal exercise. The optimal cut point to define uncoupling was an RV ejection fraction during exercise of 38%. And this also predicted a time to clinical worsening, although the numbers here are quite small. So that kind of brings us to our ongoing project, which is to develop an RV stress test. One of the things that we're doing is exercise MRI. This is a less invasive way to measure ejection fraction during exercise. This is an MRI compatible bicycle ergometer. This is a healthy volunteer who's going into the magnet there. And of course, the normal response is to see an increase in both RV and LV ejection fraction. We're also looking at different echo measures with dobutamine and exercise, and also ones in the cath lab. Just like we talked about earlier, the diastolic function also matters. So this is a paper that we published in the ERJ led by Stephen Su earlier this year, where we looked at the reserve capacity of patients with pulmonary arterial hypertension undergoing supine exercise. We divided it by those who had high cardiac index reserve and low cardiac index reserve. You can see the difference in pressure volume loops here. The stroke volume goes up in these individuals. It really does not go up very much in these individuals. The first thing we found is that those individuals with low cardiac index reserve, which is the black circles here, became a lot more stiff during exercise. Their RVs became a lot more stiff, shown here by the end diastolic pressure volume relationship and here by the beta coefficient. And what happened to hemodynamics? Well, as you might expect, those individuals who had stiffer RVs had more significant rises in right atrial pressure. Actually, wedge pressure went up the same in both groups. So what that actually meant is their LV transmural pressure, the difference between their wedge pressure and their right atrial pressure, actually became more negative. This is the LV transmural pressure is really an estimate of true preload. So you can have a high wedge pressure, but actually low preload if your LV transmural pressure is low. And so this was indicating that patients were actually developing pericardial restraint. So the patients with high cardiac index reserve were able to maintain their normal RV-LV relationship, but those that lacked reserve, where they had a stiff RV, they begin to develop pericardial restraint and a relative LV underfilling, which limited cardiac index augmentation during exercise. So can we make it any more simple than that? And it turns out that we actually stress the right ventricle every minute, and in fact, every couple seconds. You guys are all stressing your RV right now. In fact, every time we take a breath in, we're stressing the RV. In fact, when we inspire, we increase RV volume by about 50 milliliters during inspiration. And so can we leverage that, and specifically in the cath lab, to assess the right ventricle? Another one of my favorite studies out of University of North Carolina in Chapel Hill, published last year in CHEST, where they looked at the ability of respiratory variation to predict outcomes in patients with pulmonary hypertension. So here's a normal right atrial pressure tracing. You can see normal respiratory variation. And here's the wedge pressure tracing, again, significant respiratory variation. But here's a patient with pulmonary hypertension that lacks respiratory variation in their right atrial pressure. So what does this patient actually have? They actually have a resting Kussmaul sign, right? So when they inspire, when they increase that RV volume, we don't see the traditional drop in pressure as intrathoracic pressure actually falls because of that restrictive filling of the right ventricle. The investigators went on to show that if you lacked respiratory variation in your RV pressure tracing, you were more likely to be hospitalized in the next year. And there was a strong trend towards an increase in mortality. And this is despite no significant difference in the absolute right atrial pressure. So 8 versus 10. And so one of the things I always tell my trainees is we can learn a lot more from the right heart cath than just the absolute numbers. We can learn a lot by just looking at the waveforms. This is something we're looking at now to try to predict right heart failure in patients undergoing left ventricular assist devices. Hopefully we'll have that shown at AHA this year. So I mentioned I wanted to talk about LVADs a little bit because right heart failure is a significant problem. So can we use these principles that we've just discussed, specifically reserve, to predict right heart failure in patients undergoing LVAD? But first of all, why the heck is it so hard? Well, we know right heart failure after LVAD is bad, right? It's bad up front, it's bad long term. Unfortunately, so many of the risk scores that we've developed, right? When I was a fellow, all you had to do was develop a risk score. You could publish it at your single institution. But in subsequent validation cohorts, none of them actually pan out very well. Even very large ones like the Euro RV score, which is thousands of patients, pretty limited in subsequent validation cohorts. So why is it so hard? And why does the RV fail after an LVAD? Well, one possibility is that we're seeing an increase in RV afterload after the LVAD. That's a possibility, right? We talked about the afterload sensitivity of the patients of the RV. So this was a study that we did to try to better understand that. So this was a collaboration with Vanderbilt of patients who had an LVAD between 2005 and 2012. They all had multiple hemodynamic measurements. So before LVAD implantation and at multiple time points after the LVAD implantation. And we excluded a lot of patients. Why did we do that? Well, we wanted to really isolate the impact of the LVAD itself on right ventricular function. So we excluded anybody who was on inotropes at any time point, vasopressors, pulmonary vasodilators, or alternative mechanical support. So that left us with about 2/3 of patients with the old HeartMate 2 and about 1/3 with a hardware HVAD. So what happened to hemodynamics over time? What happened to RV afterload? And I'll just draw your attention really to the green bar there, which is pulmonary vascular resistance. And you can see that after LVAD implantation, pulmonary vascular resistance fell, and it actually continued to fall over follow-up. How quickly does that occur? It occurs really, really fast. In fact, it occurs by post-op day 1. And so in this study, you can see marked decreases in mean pulmonary pressure, transpulmonary gradient, and pulmonary vascular resistance. And that's true even in patients who have higher PVR, so-called fixed pulmonary hypertension. Persistent pulmonary hypertension after an LVAD is exceedingly rare. If you guys were part of the Soprano study, that's why it was so difficult to enroll, because patients just don't have it, at least very often. So if it's not RV afterload, then what the heck is happening to RV contractility after an LVAD? And to understand that, we have to go back to anatomy a little bit to talk about how the heart is made up in terms of their fibers. So the ventricle, this is a Torrent-Wass helical model of the heart, and it states that the ventricles are composed of 2 interconnected loops, a basal loop and an apical loop. That basal loop, which makes up the RV free wall, predominantly has a transverse muscle orientation, where the apical loop is composed of both an ascending and descending limb and actually forms a helix with oblique fiber orientation. This comprises the LV-RV septum as well as the LV free wall. Now, it turns out that if you take a sarcomere and you stimulate it, it only contracts by about 15%. And so if you had a heart that was composed only of circumferential fibers, our ejection fraction would be about 30%. It's the oblique fiber orientation, that helix that's formed, the spiraling that occurs, that actually allows us to have an ejection fraction of 60%, allows us to eject into a high afterload circuit like the systemic circulation. These are the fibers that are actually in the RV septum. And because of that, the RV septum is actually responsible for the lion's share of ventricular function, at least in healthy individuals, where the free wall, composed of those transverse fibers, is much less robust and is much less responsible for overall ventricular function. So what happens to the RV septum during cardiac surgery? So this is a study of 9 patients undergoing CABG surgery, and the investigators put a pulsed wave tissue Doppler on the RV septum. And what you can see here is at the time of pericardial incision, they saw in all of these 9 patients a really significant reduction in RV septal function. So is the pericardium responsible for some of that RV septal function? This is work from Paul Forfia, where he took 4 different cohorts: normal individuals, those underwent a heart transplant, CABG surgery, and then lung transplant. The lung transplants are unique here because of preservation of the pericardium. And then he looked at the overall ratio of TAPSE, that longitudinal motion from the septum, to overall RV fractional area change. And you can see that it was really only the lung transplant patients that maintained that longitudinal motion, where there was a decrement in heart transplant patients and CABG patients. So the question then is, does pericardial insult worsen RV longitudinal function? Maybe so. What we also know, though, is that if we can repair that pericardium, we can restore some of that motion. We can restore some of that twist as shown in this dog model here. The amount of LV twist actually declined after pericardial opening, but after repair, we see some reintroduction of the LV twist that was lost. And we know after LVAD implantation, there's a significant decline in LV twist that occurs perhaps again due to that pericardial insult, perhaps due to anchoring of the LVAD at the apex of the heart. So here the doctor is saying to the patient, your left ventricle doesn't know what your right ventricle is doing, and that's absolutely true. But the converse is not, right? The right ventricle always knows what the left ventricle is doing. And in fact, it's dependent on the left ventricle for a lot of its function. So here in this rat model of chronic RV volume overload, when we reduce preload in the LV, the RV does not like that, right? And so RV function, RV contractility declines significantly when we reduce preload in the LV, exactly what we're doing with an LVAD. So this is a perspective we wrote with Mandeep Merritt, Keir Shaw, and Brian Houston a couple of years ago, where we really detail all of these other factors that I think is the reason it makes it so hard to predict right heart failure in patients who are undergoing a ventricular assist device. We know that that RV is weaker. We've shown you that. This was a study that we did in the last year, again, comparing to normal controls, showing that patients with LVAD had reduced RV contractility and reduced RVPA coupling. So no surprises here. But I show you the study for one reason, because when you're dealing with right heart failure in those patients with an LVAD, we found is that the more significant RV dysfunction you have, as you speed up the pump, RV contractility declines even more. And there's another paper published this year that shows the opposite, but they actually did not enroll patients with significant right heart failure. So the message for me, at least, is if you have a patient really struggling with RV failure and you have an adequately unloaded LV, higher speeds are not the answer. So we talked about LV reserve. How do we assess for RV reserve and potential LVAD candidates? You might say, well, that's difficult, right? Because they can't exercise. They're probably already on dobutamine or milrinone. So how might we do that? And specifically, could we pharmacologically reproduce what's going to happen to the LV with an LVAD? That is, unload the LV pharmacologically and look at the response of RV function. So I'm going to take you back to pressure volume loops this time now. The LV, this is a patient with heart failure with reduced ejection fraction. They have low contractility. So this is our typical LVAD patient. They're very dilated and they have high afterload. So my favorite drug in the ICU is, of course, nitroprusside. And when we give nitroprusside, we significantly reduce afterload without much change in LV pressure because the shallowness of that insystolic pressure volume relationship. And stroke volume goes up a whole lot, right? It's like a miracle drug in the ICU. It goes up a whole lot as long as you can maintain your LV preload, as long as your end diastolic volume remains right here. On the other hand, if your RV doesn't work, if it lacks reserve, as you reduce LV afterload and you try to fill that LV more, it's not going to happen as much. And so stroke volume augmentation is going to be blunted if you lack RV reserve. So we wondered, could we leverage this idea to predict right heart failure in those who undergo implantation? This was a collaboration in concert with the University of Toronto and University of Pennsylvania. And as usual, none of our risk scores, none of our rescue hemodynamics, none of our echo measures predicted right heart failure. But what we found, the peak stroke volume index during nitroprusside infusion was a pretty strong predictor of those who ultimately developed right heart failure after LVAD implantation. We went on to show that if your stroke volume index was above 22.1 during nitroprusside infusion, that it was very unlikely those individuals were going to develop right heart failure. Now, clearly this is not perfect, but I think it can be used for two reasons. One, it can help us have shared decision-making discussions with our patients, saying you're going to be perhaps higher risk of right heart failure. Is this something that you still want to go through? I think many patients will still say, yes, I want a chance. But the other thing I think it can do is help us to define a high-risk cohort of patients where we can study mitigation processes for these patients. Right after we published that, there was a study published in Europe from this Italian center that basically showed the same thing, that stroke volume index, peak stroke volume index was different between those who did and did not have right heart failure. But they extended our research by also measuring PAPI. I told you that was a good measure of right ventricular function. You can see the patients who did not have right heart failure had a significant increase in their PAPI with nitroprusside, where those who actually developed right heart failure had no significant increase. So what if you have that patient who appears to be high risk with these type of testing? What can you do? And so one of the possibilities is a less invasive implant strategy, perhaps one that preserves the pericardium. This was a multi-center international retrospective collaboration we did with a couple centers in Germany. And what we found compared to the conventional median sternotomy, this less invasive surgery was associated with less right heart failure in both the overall cohort as well as a propensity match cohort. There have been subsequent studies that have not shown the same benefit, although I think it really is surgeon dependent. And if your surgeon and your team are passionate about doing this and doing this well, where it might be able to make a difference. So in the last few minutes, I want to touch on treatment of right heart failure. And of course, it's not so easy. But if we go back to the first slide I showed you and we think about our determinants of right ventricular function, preload, afterload, and contractility, it really gives us a construct into which we can go about treating these patients. So preload optimization. So if I were giving this talk 30 years ago, that was longer than when Texas won the national championship, by the way, we would be saying, give these patients fluid, right? We know, of course, that's not the right approach. In fact, we want to optimize the preload, and almost always that's taking fluid away. And we traditionally do that with diuretics, loop diuretics, sometimes thiazide diuretics, and perhaps in the ICU, ultrafiltration. And that's so important, right? Because I described to you that the RV septum is so important to overall function. As that RV becomes volume overloaded, we reduce this RV septal function capacity. And so we want to bring that septum back over and allow the RV to eject. We also know that a dilated RV has less reserve. Well, why is that important? Dr. Bagani's never had a patient with right heart failure, but if he did and that patient came out on multiple inotropes, that RV is going to respond less to the inotropic stimulation in a volume-loaded RV compared to an optimal preloaded RV. What else can we do? Well, certainly in the ICU, we can manipulate things like hypoxia and hypercapnia. We know the more acidotic you are, the higher your PVR is. Also, the lower your PO2, particularly as you go below 60, the more increase in PVR. So we want to avoid those, of course. We want to reduce atelectasis. Atelectasis will also increase your pulmonary vascular resistance. And we want to avoid excessive PEEP and hyperventilation. So here we can see to a PEEP of 5 actually improves RV function a little bit. But after you go above 5, we really start to see a decline in RV ejection fraction. And as those lungs become more hyperinflated and approach the total lung capacity, we see significant increases in our pulmonary vascular resistance. So rely on your critical care colleagues to make sure the RV is optimized from a ventilator standpoint. What about reducing afterload? So certainly coming out of the operating room, we can use inhaled nitric oxide or inhaled prostacyclin. We have lots of drugs in patients with pulmonary arterial hypertension, but it is mainly in those with pulmonary arterial hypertension, right? Those with left heart disease, we really don't have any great therapies. This was a table that we put together for the 6th World Symposia, highlighting really only one single center study that's never been reproduced showing improvements with pH-specific therapies in patients with left heart disease. The others have suggested harm, including FACC, which was patients who had persistent pulmonary hypertension after corrective valvular surgery. We were hoping to have better news at the 7th World Symposia, but in fact, we really didn't. None of these drugs really definitively improved outcomes in patients with left heart disease. And even the PASSION study, although it was terminated prematurely, actually there was an increase in overall all-cause mortality, although the numbers are relatively small. So what do we do to reduce afterload in left heart failure to the RV? We optimize left heart filling pressures. So this is work we did almost over a decade ago now, showing that the higher the left atrial pressure is, the stiffer the pulmonary circulation becomes, independent of pulmonary vascular resistance. That increases your pulsatile load to the right ventricle. So by normalizing your wedge pressure, normalizing your left atrial pressure, not only do you see a modest decline in pulmonary vascular resistance, but you see an out of proportion improvement in your pulmonary arterial capacitance or compliance, which then reduces RV afterload. What about increasing contractility? Well, of course, we can use our beta agonists and our vasopressors to do that. And this is a table from a study with acute ischemic RV failure and dobutamine, which is probably the tried and true inotrope that we use in patients with right heart failure. We see significant increases in cardiac index. I want to point out the other 2 drugs studied here, drugs, one being normal saline, right? So classically, we were all taught with an RV infarct, we give them saline. And that's not necessarily true. It's true if they're in a relative volume deplete state, if their CVP is low. But in this study, the CVP was 11 to 15. You see no increase in cardiac index. And in fact, it can actually lead to pericardial restraint and reduction in overall hemodynamics and RV function. So giving everybody with an RV infarct saline is not the right answer. Nitroprusside, again, my favorite drug, but not for isolated RV failure, right? Because it's going to afterload reduce you systemically, and it's going to decrease your LV contractility and therefore your RV contractility. You may also get ischemic in the RV because the RCA is dependent on blood pressure for its filling. So try to avoid systemic hypotension. If we look at all of these drugs, all of them increase cardiac output for the most part, but they also increase pulmonary vascular resistance. The only two that actually improve RVP coupling is dobutamine and milrinone. But again, we have to be careful with milrinone because of that systemic vasodilatation that occurs and the potential for hypotension. So we have one EP in the audience. So I promised I was going to talk about heart rate just briefly. So this was work that we did in patients with pulmonary hypertension, where we looked at our right atrial pacing to increase heart rate to improve hemodynamics acutely. You can see as we increased heart rate, we saw an increase in cardiac index, which is actually different from what happens in the LV. Why did this occur? Well, we saw both increases in load-independent contractility, which is not a surprise, but we also saw RV end-diastolic pressure fell. And so what we believe was happening here is these patients all had high RV-EDP, and as we paced them, we actually saw a reduction in pericardial restraint and improvement actually in hemodynamics. So we were very interested in this observation. I thought, well, what about in LVAD patients? At least some of the surgeons I'd worked with in the past, they would actually bring patients out of the operating room and pace them with their native pacemaker at higher heart rates to improve their hemodynamics. We were a little disappointed that we did not see that when we studied it in a prospective manner. There was really no difference in cardiac index when going from different beats per minute, but in the first pacing increment, the second, and the third. We did not see that same fall in right atrial pressure that we saw in patients with pulmonary arterial hypertension, and actually a modest increase in their wedge pressure. And this was true regardless of the pacing modality, whether that was bi-V pacing, isolated RV by RA to RV pacing. I'd also like to remind you that the right atrium is important and it contributes to right heart function, and that's particularly true in patients with pulmonary hypertension. In fact, it's been estimated in patients with pulmonary arterial hypertension that the right atrium is responsible for about 50% of the overall TAPSE. What does that correlate in terms of stroke volume? In normal individuals, the right atrium is responsible for about 10% of stroke volume, or in patients with PAH, it's upwards of 40%. So this really speaks to the importance of maintaining sinus rhythm in those patients with pulmonary hypertension. And finally, despite our best efforts, right, sometimes despite optimizing preload, afload, and contractility, we still fail. And that's when we have to bypass the need for inotropes using our temporary MCS devices, or perhaps even VA ECMO. This is a review that we just published in the Journal of Heart and Lung Transplant with my junior colleague, Tony Carnicelli and Manri Kanwar. We talk about all these different acute RV mechanical support devices, as well as offer a weaning strategy. If you're interested in this, I'd recommend that you take a look. Timing is, of course, very important. So this is the most recent INTERMAX analysis. And what this is actually looking at is patients who ultimately required a temporary RVAD, but the strategy, whether they got it up front in the operating room at the same time, concurrent BiVAD, or if it was sequential. That is, they came back to the ICU, they kind of floundered there for a little bit, they had to go back. And you can see in this propensity matched analysis, there's a clear signal here that those individuals where we wait, where we have a sequential approach, that actually have worse outcomes than if they actually upfront got this in the operating room. And so at MUSC, we don't really consider it a failure if patients are coming out with an RVAD or a temporary RVAD, rather that we want to support that RV through times where there could be bleeding, where there could be a lot of fluid shifts, and then wean it down slowly. So to summarize, when we think about the right ventricle, we have to consider the mechanistic determinants of right heart function to assess and treat the RV. Assessment of the RV is complicated by afterload sensitivity. The single beat estimates, if automated, may be coming to a clinical theater near you. The pulmonary artery pulsatility index, TAPSE to PAPSE ratio, global longitudinal strain, and perhaps the TAPSE to or S prime to RV area may be reasonable surrogates. Consider multiple measures when you're assessing the RV. And finally, treatment involves preload optimization, afterload reduction, increase in contractility, rhythm control, and perhaps support devices. So with that, I'd like to thank you very much for the invitation again, and also encourage you to come to our 5th annual Charleston HFpEF conference, which is occurring in July of next year. Thanks again, and happy to answer any questions you have.
Thank you, Dr. Tedford, for that tour de force talk on all things RV failure. We have about 10 minutes for questions. Any questions from the audience? As we're waiting for questions, I can get started. So I think, one of the things that struck me is the discussion about the treatment and that last slide where you talked about the concurrent BIVADs. We have our transplant meeting today at 4:00 this afternoon. And one of the things that we're going to review for all our LVAD patients is what their RV looks like going in and that decision whether or not to plan to do the BIVAD going into it. Could you talk a little bit about your experience and how you think about that and when you decide?
Yeah.
Is it made ahead of time or is that in the OR?
So our discussion happens just like yours at our LVAD and transplant meeting. And we identify at that time patients that we feel are going to be high risk. And we kind of put that on the radar of our surgical colleagues and say, hey, we think this person is high risk. And of course, we leave it up to them based on their assessment in the operating room. But in those individuals, we will err on the side of going ahead and implanting at the time of the surgery, unless the RV just really came around unexpectedly. And of course, there's sometimes we don't predict it and they need it. But I think in those cases in particular, we've kind of said, if we're in doubt, let's go ahead and put it in. We can take it out a day later if we need to. But really where we get into trouble is when those get back, we have escalating inotropes, the CBP goes to 22, there's bleeding, and then their kidney starts to fail. And even if we get them through that, they're in the ICU for a couple of weeks and taking up beds, which is always at a premium.
Victor.
Brilliant talk. Really good to hear from you. So I have a question about the treatment of RV failure or pulmonary hypertension patients who don't have PAH. So mostly those HFpEFers. Yeah. There's been a lot of excitement in trying to find effective treatment options. Some of them have been negative. Where do you think we are in finding new therapies that may help patients who have pulmonary hypertension in the setting of heart failure or RV failure in the setting of heart failure in the near future? And I don't know if you can share some of your insights.
Sure.
About that.
Well, so you and I have talked about the Cadence study. So this is, of course, off-label, but is a study, phase 2 study in patients with combined pre- and post-capillary pulmonary hypertension and HFpEF. So they actually all have a PVR above 4 Wood unit. So this is studying sotatercept, which is kind of a novel pH drug, was markedly positive in the pH trials versus placebo. All of our other studies that I showed you that have targeted the pulmonary circulation have been negative. Yet this drug perhaps is a little bit different. It may actually remodel the pulmonary circulation. It may actually have some benefits on the heart itself in both the LV and the RV. And it also raises hemoglobin, which is kind of interesting because so many patients with HFpEF have comorbid anemia. I do think that if this is a negative study, that targeting the pulmonary circulation is probably the wrong approach, because I think this drug should help. It should do it, with the caveat that targeting the pulmonary circulation of these people may not be the right approach, right? Because there's always some in people's back of their mind that, well, this pulmonary hypertension is reactive, right? It's protective, so we don't flood the LV. And there's actually some data to suggest that could be true. So I think that's one thing, right? So targeting afterload. There are a bunch of other novel therapies out there to include, I mentioned the HELP study. This was levosimendan. Levosimendan, as you know, is not approved in the United States, is approved in Europe. And it was studied in patients who had pulmonary hypertension and HFpEF. And it did not meet its primary endpoint, which was exercise wedge pressure, but it actually lowered filling pressures across all stages of rest and exercise and resulted in a significant increase in 6-minute walk. So that's being studied now in the LEVEL study. But the mechanism of action of levosimendan was not what people thought. As you know, it's a calcium sensitizer, but it really did not appear to increase inotropy of the RV. What it actually did is it led to vasodilatation of the venous circulation. So it actually reduced the stress blood volume to the thoracic cavity. And so I think in patients with HFpEF and PH, those individuals all truly have HFpEF, and they all have too much volume in their chest. So I think that could certainly be a novel strategy. The problem as it moves into more just HFpEF is I think a lot of patients with HFpEF either are misdiagnosed as having preload insufficiency or they have concomitant orthostatic hypotension. So people may be aware of the splenic nerve denervation story where half of people responded and half of them did not. You could actually predict response based on their systolic pulse pressure when standing, again, suggesting that those individuals had some orthostasis. And so as that drug moves into a more common HFpEF population, I'm a little bit worried that those type of patients are going to be enrolled in that study. But if you actually only target the ones with PH, I think those patients have real disease and benefit from preload reduction. So I think that's out there. There's some other devices that are out there that may augment right ventricular function. And of course, we're still looking for the RV inotrope that doesn't increase mortality as well. There have been some studies with oral milrinone, and it seems like that's always been in production for many years. So, you know, a lot more we can do, a lot more we can learn, but I think it's an exciting time to be interested in the RV.
We have a couple of questions online also.
Please. Do you see them, Victor?
Yeah, no, I'm happy to go through those questions. So Scott Ketchum is asking, in PAH patients admitted to the ICU with RV failure, shock, and with a heart response that might be considered inadequate or inappropriately low, do you consider RV?
Yeah, that is a really great question. I think that it would be wrong for me to say that I recommend it. I think that in an individual patient, if all else is failing, it would be a reasonable thing to attempt looking at that individual response, right? And particularly if the right atrial pressure is high. You know, again, I would hesitate to make any recommendations based on one physiologic study of, 20 patients. But we did find it intriguing. And if you follow the kind of pacing LV literature, this was tried many years ago, right? And increasing heart rate in the LV did not result in improvements in hemodynamics. There is some data in the post-CABG literature that it might, but we were a little surprised that we didn't see that in the LVAD patients. So, reasonable, but not something I could say, yes, absolutely do it. Couple of questions. Go ahead.
So Megan Cannon says, in terms of post-operative atrial fibrillation, how aggressive are you with getting patients back into normal sinus rhythm who have pulmonary hypertension? Does hours versus days in post-op AFib make a difference in terms of RV failure outcomes?
So certainly in patients who have hemodynamic compromise, very, very aggressive. And I would say a lot of those patients will. So I would say we're very aggressive. In terms of those who are kind of holding on hours versus days, I don't necessarily think that makes a huge difference if they tolerate that initial hemodynamic insult of the atrial fibrillation. I do think, though, that as we look at kind of the emerging literature with tricuspid regurgitation, right, we have kind of two different phenotypes, right? We have an atrial predominant TR, and a lot of those patients are probably untreated, persistent, or permanent atrial fibrillation. And then we have our more ventricular TR, which is truly ventricular dilatation. I think we are missing an opportunity to be aggressive about those atrial patients. And I have one in particular right now that we've been, for whatever reasons, have gotten delayed, and you can just see the TR getting worse over time. So I'm much more bullish on a rhythm control strategy in anybody with pulmonary hypertension. Yes.
Dr. Cohen.
Thank you. That was a fantastic talk. I really enjoyed. I think I heard you say that with RV dysfunction that you prefer dobutamine over milrinone, and RV dysfunction. When we see this up in the CCU, oftentimes we're also dealing with cardiorenal syndrome. Have you seen cardiorenal syndrome worsen by milrinone? Are there examples of that? And is dobutamine something that you think helps in those situations?
Sure. Well, let me first say that in patients with concomitant left heart disease that are not hypotensive, I still think milrinone is a great option. And I would still say that I would use that because we're also trying to treat the LV and have some systemic outflow reduction. In patients with pure PAH, I would hesitate to use milrinone because of that systemic vasodilatation and the worsening of right heart function. In terms of cardiorenal, theoretically, the milrinone could start to actually accumulate and may become a higher effective dose in those with renal insufficiency. So I'm always kind of keeping an eye on that. And of course, the half-life is a lot longer, so it's going to stick around if you run into trouble. But I have not specifically seen, worsening cardiorenal syndrome with milrinone unless those patients are getting hypotensive. So I think it's certainly for concomitant left heart disease, a very reasonable approach. I think for PAH, I usually stay clear, but there's always exceptions.
Awesome. Question? One more. Let me take one more from the audience, and then Dr. Tedford will be here after to answer some more questions.
Sure. There's been some work on the LV side with vortex formation, really seen in MRI studies recently. Is that something that I don't think I've ever read something about RV vortex formation and bioenergetics?
Yeah, so that's a really, really great question. So if you follow the shunt literature in HFpEF, there's a lot of talk right now about this vortex formation, specifically actually in the right atrium. And so that an intraatrial shunt device may actually interrupt that vortex. And the vortex is actually responsible for about 40% of RV filling. And it actually comes in such a way that it goes straight out to the RVOT. So you almost kind of bypass the need for right ventricular function because of that vortex formation. And so if you put a shunt in the intraatrial septum, you now make this much less efficient. And there's some thought about why that's what we're seeing with intraatrial shunts. There are some other shunts, and I happen to be on the steering committee for one of those that shunt a different way. So you actually maintain that right atrial vortex and then filling of the RV. So yeah, I think there's definitely something to that because certainly it improves efficiency on the right side of the heart. And I think another important reason why maintaining right atrial function is necessary.
Awesome. Thank you again, Dr. Tedford.
Well done. Frank, how are you?
Thank you. How you doing?
Good to see you.
Thank you.
You bet.
Great talk.
Oh, thank you.
Appreciate it. Hopefully we'll see you for the board.
I accepted. Yes, I did. So thank you very much. For the other faculty that applied, when they're going to hear?
Everyone should, we have some presentations now, so everybody should.
Oh, really?
Should do.
Okay.
Is there somebody?
I had a junior faculty, Tony Carnicelli, he actually wrote that temporary MCS review with me and Reed.
Because people are meaning to back out. or
Okay.
something like that. So send me his name.
Okay.
And contact information and the potential talk that he might do.
Okay,
And then, we can.
Okay.
We're still.
I appreciate it. He wrote the piece in Sir Card Failure too about our temporary MCS coordinators and the role that's played in quality and improvement of outcomes. So I think he's a critical care guy to have some good stuff to say.
It was interesting that, you commented